Well, that was actually a good intro to just kind of getting the basics of interlaminar and transforaminal technique, and I think we'll all go in the lab later and kind of really get the details of how to do that technique in a reproducible fashion. So I'm going to talk about what we call the benefit zone of endoscopic spine surgery. Why would you want to incorporate endoscopic spine surgery into your practice? And I want to start off with this quote: the farther back you look, the farther forward you can see. And really, I think that's important for understanding endoscopic spine surgery and where we started and where we're going. So let's start off way back, 1829, the first lumbar laminectomy. It was performed in the US, and at that time, most surgeries ended in mortality and morbidity. I mean, we're talking about 90% mortality rates for surgeries. And that's probably because that was before anesthesia. So actually the first laminectomy was actually a wide awake laminectomy, I think. Albert's taken it going all the way back. And I think at the end of the day, we're seeing that spine surgery, when it first started, was very premature, and it wasn't until, actually all surgery was premature. It wasn't until the 50s and 60s we saw germ theory, we saw the antiseptic technique principles, and that's when really surgery just took off. We saw the first ORIF, we saw the first brain surgery, the first appendectomy, the first heart surgery, and that was towards the end of the 19th century. But really, if you look at it, 1856 was when the first endoscope was made. And that was actually before all these surgeries. And actually, the first endoscope was actually this long tube filled with mirrors, and they had this little chamber. For getting illumination, you had to use burning kerosene. And they would stick this in patients' urethras. And you can imagine it didn't end pretty well. But I mean, that's our first experience with endoscopes in surgery. And really, for the most part, it was just diagnostic. And then, 1895 with the development of the X-ray, and that's when really orthopedics and spine surgery really started taking off, when we were able to visualize the bony anatomy. And the first 50 years of the 20th century, really it's the rapid evolution of open spine surgery. We had the first fusions, we had the first cervical laminectomies, really the basic building blocks of spine surgery were being developed. And at that point, it was just big wax. It wasn't until the 1950s when the development of the microscope happened. And the microscope plus two more inventions, the MRI and the CAT scan in the 70s and 80s, really changed spine surgery. We moved from these big open spine surgeries to these what's called the microsurgical spine surgery. And we saw the first idea of minimally invasive, which was the Wiltse approach, which is the idea of not doing subperiosteal dissection. And then we saw Williams borrow techniques from Europe, and the Williams retractor and then the McCullough retractor, and really popularized the interlaminar approach, which really was the mainstay of what's called non-disruptive spine surgery. And in parallel, we had, in the 1930s, we had the first laparoscopic surgery, and that was in Germany, and that was lysis of adhesions. And really, not much was going on prior to that. It was just endoscopes using for diagnostic purposes only. And then we saw the invention of the color TV in the 1950s, and then we see something happen in surgery. We see the first arthroscopic meniscectomy in Japan in 1962. And then we had this almost fervor for using cameras to visualize inside the body. Then we had the first laparoscopic appendectomy in 1983. And all while this is happening, this minimally invasive revolution in surgery didn't really quite make it to spine surgery yet. In the 70s and 80s, we saw what's the precursor to endoscopic spine surgery, which is in Japan, Hijikata, he did the percutaneous nucleotomy, essentially taking a large cannula, sticking in the disc space, and Cambin in Pennsylvania was able to actually expand on the technique. And Cambin actually reported 88% success rate. And how could someone just stick a cannula in a disc space and get an 88% success rate? Well, at that point, the outcomes we're measuring is excellent, good, fair, and poor. I mean, it's leads to say subjective, but at the end of the day, that was the precursor, and we saw the next 50 years, we saw this battle between the microscope and the endoscope. And it wasn't until 1986 where really we saw all laparoscopic and arthroscopic surgery really take off, is because we were able to get the better visual imaging on these cameras. And then you see this fervor in spine surgery. You see the thoracic VATS procedure. You see this is a procedure where they're doing thoracic discectomies with a laparoscopic camera. Then you see laparoscopic ALIFs. You see laparoscopic discectomies. And if you look at the data, it was horrible. I mean, it was high morbidity, high mortality, and really it was kind of made a lot of surgeons in spine surgery, at least, stay away from the camera. And then you had in 1996 the first lateral interbody fusion, and actually the first lateral interbody fusion was done with an endoscope. It was done in 1996, and if you look, that's the first publication of going trans-psoas. He actually insufflated in the retroperitoneal space, and then was able to dissect through the psoas, and then put a cage in there. And that actually was the basis for Pimenta's lateral interbody fusion in 1998. And in 1997, we saw the use of the endoscope for tubes. And that essentially morphed into just, first we had a tube. The first tubes were having an endoscope pretty much at the end of the tube. And that formed into what we see, tubular surgery that we see practiced today. So you see, the initial fervor for cameras was kind of beat by the microscope. But in this parallel world, we saw that the first generation of endoscopy was still kind of developing. And that was really Cambin. In the 1990s, he finally converted the percutaneous nucleotomy to actually be able to see what you're doing. So what he would do is he put the cannula in there, take some disc out, and then see what he did. And essentially, that was before the idea of the working channel endoscope. And it wasn't until Tony Young in 1999 developed the endoscopic spine system. Actually, we have Tony's son here today who can probably tell us a lot more about that system. But the idea at that point was we went from the first generation where we were just sticking things in discs and then taking things out, and as the inside out, then we went to the working channel. We're going to see our instruments as they go into the disc. And it was the uniportal working channel, really the precursor to what we do today. But then the question is, by the year 2000, how come no one really did endoscopic spine surgery? I mean, that's 20 years ago. No one really did it. I mean, Dr. Young did it, but I think some people, surgeons all across the US had some reports of doing it, but it wasn't very popular. And that was because for microsurgical techniques, there's uniformity in approach, it was familiar, it was ease in adoption, and the outcomes were pretty reproducible. And the indications were very clear. And that's why it was the gold standard in the beginning of the 21st century. What about spine endoscopy? Well, it was very unfamiliar. It was a large technical learning curve, and there was very limited learning opportunities. At that point, you had to really go and seek it out, and it wasn't available to everyone. And there was a lot of this fear for catastrophic complications. The quality of the imaging wasn't so good. And really, the early outcomes, it wasn't as good as microsurgical techniques. And the idea was that most endoscopic surgery was inside out. We go into the disc, and if you have a sequestered disc, you forgot the disc. You didn't get it. You just got the contained disc herniations. And then the indications, they were limited versus poor. Then you start seeing surgeons adopt endoscopic spine surgery for black discs, for annular tears. And really what happened is that the spine community threw the baby out with the bathwater. And that's why there was slow adoption. Now let's talk about current full endoscopic spine surgery. Now really in 2000, we saw in Germany, Hügelin developed this outside-in transforaminal approach. This is the first time we're not going straight into the disc, where he's doing a foraminoplasty before he goes into the disc. And that's this concept of looking before you attack the pathology. And in 2005, we saw Rutten in Germany really kind of borrow from the interlaminar technique, from microsurgical technique, and start using that for endoscopic spine surgery. So this was a third generation. This is uniportal, outside-in, working channel endoscopy. And from 2005 to 2020, for the past 15 years, we see the rapid explosion. We see improved technology. We see better cameras. We see expanding indications. We see the evidence growing and worldwide adoption. If you look at just the amount of publications in the past 10 years, you can see it's just skyrocketing. And since 2016, if you look, it's interesting that most publications are from China and South Korea, and the US is number 3 in that list. The question now becomes, we just saw in the past 5 years, we're seeing this idea of biportal endoscopic spine surgery. The question is that going to be the 4th generation? Is there going to be some combination of that? So if you look at current full endoscopic spine surgery, there's really expanded indications, pretty much all disc herniations, lumbar stenosis, thoracic, cervical. We're talking about revisions, fusions, tumor, infection. Really, it spans the gamut. You can use it for everything. Now the question is, how is the endoscope advantageous? Well, the working channel endoscope provides a field of view about 0 to 15 or 30, depending on the scope you have. And that allows for being able to look and look around angles, or look under corners, essentially. Now you can see that the diameter gives you the maneuverability, plus the field of view. It really lets you kind of, again, cut around corners and preserve bone. And you can see that this is a CAT scan of a tube versus an endoscope. You can see how much bone is taken out with a tube versus an endoscope, and that's because that simple ability to look around corners. And then what about why is it advantageous? Well, the transforaminal approach, it was novel because it allows access to different regions of the spine that you couldn't access before. First, it makes sense we can access foraminal pathology and extraforaminal pathology, but then we can also access the ipsilateral lateral recess. We can access the ventral epidural space. Really, we can remove discs, shave down vertebral body osteophytes, and Osama did a great job presenting how you can see the traversing nerve root after you remove the gale ligament and some superior articular process. And really, that allows for you to safely shave bone ventrally, which you couldn't do before safely. And then in terms of biomechanics, this is perhaps the least destabilizing approach in spine surgery. This is from the masters, Punjabi and White, in 2007. They looked at the difference in foraminal area comparing a posterior approach versus transforaminal, and there was way more increase in foraminal area with no concomitant increase in stability. And I think that goes to say a lot. The transforaminal approach is a very powerful technique, and I think for certain pathology, it's great that we have that in our tool belt. The question then becomes, when is it advantageous? Well, we all know, for the most part, endoscopic spine surgery is for decompression procedures. And we all know that a good decompression is a happy patient. But we all know that not all decompressions are equal. This is a thoracic disc. And a lot of decompressions can vary in their invasiveness and complexity. And this is a TLIF case that backed out. So the point of this talk is to talk about the benefit zone. And the benefit zone really is that the benefits of endoscopic spine surgery really increase when the alternative options become increasingly invasive and complex. And we're going to start with we're going to go through 3 tiers: low complexity, moderate complexity, and high complexity, and kind of see where the benefit develops for endoscopic spine surgery. So for the herniated disc, let's get some basic benchmark data on open discs. Some of the best data we have is from the SPORT trial in 2006. Now, look at this is just the basic. We have a reoperation rate about for 2 years about 7 to 10%, a recurrence rate about 3.2%, and overall, if we look at the overall complication or adverse event rate, it's about 20%. Now that seems very high, but these aren't serious complications. They're just literally just listing what problems happen after the surgery. Why did the surgery not go exactly as planned? And that number is pretty high. Let's look at the first endoscopic randomized control trial. We see a prospective randomized control trial, 100 patients, 100 versus transforaminal versus open microdisc. You see no real difference in outcomes. Reversion recurrence rate are pretty much the same. But we start seeing this trend towards less postoperative pain and less use of pain meds postoperatively, less work disability. And really, we start seeing this idea that Dr. Mahan published before, is this complication rate's lower. We see 10% in endo versus 25.2. Again, these aren't really serious complications, but they are complications in the strictest sense. Now let's look at the numbers again. These are the list of the complications that exist. And most of the complications for endoscopic were just reoperation for recurrence. And that's 10% versus 25%. You can see we have wound complications, paresthesias, hematoma, infection. So let's go talk about the next randomized control study, because I'm looking at only the best data that's available right now. And this is a study from 2017, prospective, 74 patients, transforaminal, 69 open disc. We see, again, functional outcome is pretty much the same. Revision rate, pretty much the same. Complication rate is similar. But again, the most common complication for a transforaminal approach is just transient dysesthesias. So I think we're trying to see that qualitatively the complications are different. And one important thing that I saw is that in a lot of publications that the endoscopic group had less leg pain at 2-year follow-up. And what I think, this is probably due to less retraction. I mean, that's the only way I can understand. Why is there less leg pain, and it's because with the endoscopic technique, you're really not retracting. And endoscopic group was more satisfied with the procedure, shorter hospital stay as expected. Now, this is a really recent article that came out about a year ago. This is from the Netherlands, a prospective randomized control study, 1 year out. And again, similar outcomes. You know, we're seeing the trend here. It doesn't matter what you do. If you take the disc out, patients will get better. But the endo group, as expected, has less opioid use. And again, we see the same trend, greater improvement in the leg score at 1 year. Again, is it because there's less retraction? I think that's the hypothesis that I'm going to stick with. And again, the complication rate is pretty much the same. You can see that there is definitely more complications in the open group, but again, it's non-significant. So let's look at the risk profile for lumbar discectomy. If you look at it, really, aside from this, for the most part, the complication profile isn't that bad for a discectomy. And that brings the point is that for a low complexity and low invasiveness case, like a discectomy, really the benefits of endoscopic surgery are really marginal. I mean, it's maybe great for marketing, but at the end of the day, if you're looking at the real data, we need a very high-powered studies to be able to detect these differences because they're so subtle. But let's talk about more moderate complexity, the invasiveness with spinal stenosis. Why is this more moderate? Yeah, it's a simple LAMI, but the patients are more complicated. You have patients who are older. You have patients who have more comorbidities. You have patients who are higher risk of complications. And then you have patients who have spondies and scoliosis as well, which complicates the picture. So these laminectomies aren't just so straightforward. And the best way to understand that is look at the best data. The best data is randomized control studies. And this is a study from the New England Journal of Medicine looking at 247 patients, the Swedish spinal stenosis study. They were randomized to decompression versus decompression infusion, and they had a subgroup analysis of people who had stable spondies. Really, again, it's interesting, no difference in clinical outcomes, but the reoperation rate, there was no difference. So really, for stable spondies, no difference between decompression and fusion. But you can see the reoperation rate's still pretty high, 22% versus 21% decompression. And let's look at the adverse events. These adverse events aren't trivial. I mean, for open lumbar laminectomy, a basic lumbar laminectomy, we're looking at a rate of adverse events of 40%. I mean, I know no one's going to say that, hey, I have 40% adverse events with my laminectomies, but this is the best data. And for fusion, it's 45%. So the idea is that we're seeing that these open procedures, they're not as benign as we think. And it's always easy for us to say it's benign because we're not the patient. You look at the SLIP study, again, another great randomized control study, 66 patients. They looked at non-mobile, single-level grade 1 spondies. Again, the outcomes were similar. But they did have a very marginal improvement in the fusion group in the SF36. But again, the fusion group had higher EBL and higher hospital stay. But again, we're looking at this, and the reoperation rate for an open LAMI for a stable level grade 1 spondy is a 34% reoperation rate. That's pretty high. Versus 14% for decompression and fusion. So I think what we're looking at is these procedures, whether you do decompression or fusion, in certain subgroups of patients, are showing higher adverse events. You can see this open lumbar LAMI, 40% adverse events versus 20% for fusion. Now, again, sports study, this is one more study. This is the last study for looking at good data. Reoperation rate at 2 years, 7%. Reoperation at 4 years, 13%. And their rate of adverse events for the sport trial, 37%. Now, what about endoscopic spine surgery for stenosis? This is one of the few randomized control studies looking at treatment of spinal stenosis with the endoscopic approach. Clinical outcome, no difference, but look at the complication rate. 1.2% versus 8.8% for their open group. And obviously less opioid use, quicker discharge. And Christoph published this, as well as Dr. McGrath, this retrospective cohort study looking at just comparing endoscope versus a tube. And we saw that the endoscopic surgery, as Christoph described this when he was first starting, was obviously a lot slower. But the hospital stay was still a lot shorter for the endoscopic patients. And then at 1 year follow-up, there's less back pain, less leg pain, less disability in the endoscopic group. And this was all significant. And most important, the reoperation rate. At 1 year, the endo group had 2% reoperation rate versus even the tubular group had a 7%. This is better than open. So we're saying open's the worst, tubes, right, better, and endoscopic's better than that. And you can see the adverse events, okay, 26% versus 8%. So we're seeing this pattern where endoscopic really has this less complications, a very favorable risk profile. What about an isolated radiculopathy and scoliosis and spondy? Well, if you look at the old evidence, doing a laminectomy in this kind of patient is almost a 37% reoperation rate. That's high. Now, what about if we do endoscopic techniques? So we published this paper looking at the specific subgroup of patients, looking at scoliosis or stable spondies with lumbar spinal stenosis, and we compared tubular versus endoscopic. And you can see that overall outcomes were similar, but the complication rate was significantly lower in the endoscopic group versus the tubular group. Again, we're looking at endoscope versus tube. This is even better than open. And if you look at this is a 6 randomized control studies looking at 646 patients, comparing endo for microscope versus microscope for spinal stenosis. And you can see these are all the studies that we mentioned, 2 of them from Korea, 2 from Germany, and 1 from Saudi Arabia, and 1 from China. And you can see that endo had greater leg pain improvement. When you're looking at all this data, it has greater leg pain improvement and a decreased risk of complications. Again, it's kind of harping on the point that there's better outcomes for this specific subgroup. Now let's take it all and kind of summarize it. If you look at the risk profile for spinal stenosis, all comers, we start to see a big difference. We start to see that when you start to use endoscopic techniques, you really get into the benefit zone of endoscopic spine surgery. And you can see that for increasing complexity, the benefits of endoscopic spine surgery are better seen. Now, what about high complexity, high invasiveness? We're talking about cervical, thoracic, revision, fusion. This step, to get to this step, you have to be able to get the first steps first, be able to do a discectomy, be able to do a laminectomy, and then you can start applying these principles to more complex cases, and that's when you can really have the benefits shine. So what about thoracic disc? And everyone talks about thoracic disc. I know Sanjay's going to talk about thoracic disc tomorrow and show some great videos. But I think the idea is that thoracic discectomies are not just procedures we can just introduce to our patient population safely without expecting that there could be some kind of serious amount of morbidity or mortality. You can see that there's many different approaches to thoracic disc. You can have the costotransversectomy, the transpedicular, extracavitary, transthoracic, the VATS procedure. Really, if you pool these, about 20% complication rate. But 26% of these procedures were associated with significant morbidity and mortality. We're not talking about just dural tears. We're talking about people being in the ICU. We're talking about serious complications occurring from these thoracic cases. Now, look at this. There's not much literature on thoracic disc right now, but you can see this is one short series, 14 patients. They had no complications in 14 patients. This is another study, 13 patients, symptomatic thoracic disc. Outcomes, excellent, good. Only 1 complication of dural tear. It's unheard of. Now, this is a recent study just came out. I think I just read it a couple days ago. This is published by Rudin. It's full endoscopic approach to thoracic discs. And he proposed 3 techniques. He did an interlaminar approach, a transforaminal approach, and yes, a retropleural approach. I don't understand this, but apparently it works. But the idea is for the retropleural approach, took a piece of the rib out and then it was able to create that retropleural space and then have a more vertical access to the disc. And that allows you to access more big thoracic calcified disc. And if you look at his the pathology in this case, 49 disc herniations, 35 were harder calcified, 9 giant discs. Look at his outcomes. So he had great outcomes, improvement with NURIC and VAS. The complication rate, 8%. That's a lot better than 21%. But if you kind of delve into the complications, you can see that for the majority of the complications were in the retropleural group. It's expected. I mean, the VATS is going to have complications. Anytime you go and you go in the retropleural space and you have fluid irrigating there, something bad's going to happen. But interlaminar group, 7%. But only 4% with the extraforaminal. I know most surgeons here, when they go for thoracic discs, we use the extraforaminal approach, and that's a very safe approach, and we'll show that in the lab. What about cervical pathology? Well, cervical pathology, we know the posterior cervical foraminotomy really is a great procedure. There are studies that show there's less adjacent segment degeneration, and it's way more cost-effective compared to fusion. And what about compared to an open laminectomy or open foraminotomy? Well, there's way more tissue stripping. In some of these fragile patients, you can have significant pain. You can have post-laminectomy kyphosis, a lot of wound complications. All endoscopic is doing is building upon the previous tubular approach. But the real big advantage of that is that you allow a narrow endoscope and allows better reach. So there's not many articles looking at the endoscopic or randomized control studies looking at endoscopic techniques in the cervical spine. This is one, this prospective randomized control study, 2-year follow-up, 86 patients were ACDF, 89 in endoscopic posterior cervical foramen anatomy. Really, no real difference in outcomes. Similar satisfaction rate, similar complication rate. But what really popped up is that, again, we talk about the qualitative difference in complications. For an endoscopic posterior cervical foramen anatomy, the most common complication is going to be transient, like dysesthesias. That's the most common complication. But with an ACDF, you have dysphagia, you can have a hematoma, you can have scar distortion in this specific series. And if you look at this, this classic article from Hillebrand, obviously 3% incidence of adjacent segment degeneration per year, and 58% of those patients end up getting surgery. So at the end of the day, the ACDF compared to endoscopic posterior cervical foramen anatomy has its associated risks. And you can see that this study just came out a year ago, and it says that at 26 weeks after surgery, 16% of patients who had ACDF still had some dysphagia. I mean, that's real. 16% of your population having dysphagia at 6 months. I mean, these numbers these are from a prospective randomized control, prospective study that we can't ignore. So this is a pooled analysis of ACDF versus endoscopic foramen anatomy. 24 studies, 1,300 patients, ACDF versus foramen anatomy. We see, again, no difference in effectiveness. We've established that this is as good as an ACDF. But the complication profile is different. Not much difference significant in terms of statistical significance. But again, the qualitative difference in complications, the ACDF, dysphagia, and implant subsidence were the most common complication. And for posterior cervical foramen anatomy, it's transient nerve root dysesthesias, again, which at the end of the day is not the end of the world. So this is a quote from this this essay that was published right when surgery was first being developed. This is when the morbidity and mortality rates were 90%. And this is from Sir Astley Cooper. He said, "We should ask ourselves whether placed under similar circumstances, would we submit to the same pain and danger we are about to inflict?" Now, this is back then when almost every patient died. We're at a place where patients turn out pretty well, but we're elevating the standard. And the idea is by elevating the standard, we're essentially allowing ourselves to expose our patients to a better level of surgery by not looking at the procedure in a way that, hey, would I do this on myself? And most spine surgeons here would probably pick a posterior cervical foramen anatomy over an ACDF. It's almost a no-brainer. So what does endoscopic spine surgery essentially do? It provides us options to do less harm. And really, you get to see these options in specific cases. And there's certain cases where it just stands out and the endoscope just screams out to you. And this is a revision decompression. This is subsidence following ACDF causing a foraminal stenosis. This is an easy case for an endoscopic surgery. All you do is go there and just decompress the one compressed nerve root, and then problem solved. And you don't have to deal with going back in there, doing any revision whatsoever. This is a TLIF case that backed out. This could be, a large revision surgery. But this is a Christoph's case actually. He just went in there and shaved the peak interbody, and that's a great, elegant solution to this problem. And we saw Albert actually publish this out and using the endoscope for treating metastatic lesions. The idea is that we're decreasing the surgical burden for these very highly vulnerable patients. And I think it's great that we're looking for these opportunities to really showcase where the benefits of endoscopic spine surgery are. Now, what about infection? I mean, this is a great example. This is, we see these cases all the time. You have consults for epidural abscess. This is a great use of inserting the endoscope to drain a ventral epidural abscess. And I actually got this video from my good friend Vincent Hagel in Germany. And you can see he actually put this catheter in there and you see all this pus coming out. And he showed the MRI post-op, and really the epidural abscess resolved. And he did a small open tubular laminotomy at the bottom of the infection, and was able to tunnel this catheter through. And then at the end of the day, he solved this problem elegantly without exposing this patient to a large open surgery to fully debride the spine. What about morbidly obese patients? Here's another patient. This is one of my patients. You can see that I had this patient. I had to figure out what am I going to do for this patient. She had a grade 2 spondy, had disc-based collapse of 5'1". I like to do A-lifts and laterals, but I couldn't do an A-lift on her because she's just way too big. So I did a prone lateral, but then I did an endoscopic fusion. And doing this case with a tube is very difficult. I mean, it's almost impossible. I mean, how long of a tube can you use? So I think there's certain cases where the endoscope just shines, and this is one of those cases. I was able to put this cage in, a 10-millimeter cage, without a problem. Now, the bottom line is, when you start to enter this realm of thoracic disc and cervical pathology and revision cases and fusion and tumor and infection, we start to see that the endoscopic spine surgery really has the most benefits when all the increasing alternative options are becoming more complex. And I think that that's the main point of this talk, is to let you guys know that you got to start somewhere. But the idea is that when you have that tool in your belt, you can then apply it to so many different pathologies. And at the end of the day, by doing that, you're providing a better standard of care for your patients. This is just then question about arthrodesis. We're still kind of early. I think tomorrow we're going to spend a lot of time talking about arthrodesis. And I'm still trying to struggle to find where arthrodesis fits, or fusion fits, endoscopic fusion fits in my algorithm. But I'm really curious to see what the guys tomorrow have to say about endoscopic fusions. So this is just kind of bring it home. This is an article published, a 12 years follow-up report, a randomized control study comparing open ACL versus arthroscopic ACL. There's no difference between an open ACL and an arthroscopic ACL. Okay, rotator cuff. A randomized control study looking at the outcome over long term. No difference between open and arthroscopic. The question I want to ask you is how many people still get an open ACL or open rotator cuff? I can't imagine. I mean, I think I had one guy in my residency do it, and everyone thought he was crazy. So, I mean, the question becomes, in 10 years, are open disc and open laminectomies, are they going to be considered like open ACLs and open rotator cuffs? That's something to ask yourself, because I think that the way the evidence is pointing is that that's possibly going to be one of the realities of the future. Thank you.